First of all, we'd like to thank IHW Council, Bayer, for having this event over here. And I think after the lovely discussions that we had in the previous post-lunch session that we had, we are now here to discuss about this important aspect of patient voices and clinical perspectives on hysterectomies. I think quite an important aspect, I must say, because in today's day, it's important for us to make a combined decision. A doctor and a patient decides things together, and it's no longer that a doctor decides it on behalf of your patient. So that is why it's important for us to have an approach where doctor and patient decides things together, and that is why I think this is one of the most, I would say, important session to discuss on the patient's voice, which is of paramount importance in today's day. So we have our esteemed panelists with us, and I'm so lucky to have Dr. Rita Bakshi ma'am with us. Thank you, Dr. Ratna Devi, for joining us. Neharika, a good friend of mine, thank you for being here. And of course, we have Dr. Ashish Gawde from Team Bayer to be here with us as well. So we'll have a few questions which we would like to discuss with our esteemed panelists, and I hope that will bring out some voice on behalf of the patients as well, because most of them who are present over here are not only doctors, not only important people in the community, but also they are more patient-centric. They are people who are health influencers, talking more about the patient's right and what exactly is required on behalf of a patient as a doctor, how we need to take a call regarding the decisions of various things. So first of all, I would like to come to Rita Bakshi ma'am. Of course, since we are talking of hysterectomy, and ma'am is an IVF specialist, and she will be discussing a little bit about, of course, the common medical indications that lead to recommendation for a hysterectomy. We have a lot of youngsters over here, and I'm sure there are people at home who also talk, maybe your mother, your auntie, or someone at home who talks, shayad doctor ne bola hysterectomy kara lena hai. So the indications which are common and the indications which sometimes hysterectomy is done for but should not be done for. I think ma'am will elaborate a little more on the indications for which hysterectomy is apt for us.
Thank you, Priyankur, and thank you, Bayer, and thank you, IHW, for calling us here. Let me ask in the audience, how many of your mothers have had hysterectomy? None? 1, 2, 3, 4. Why? Why? Dr. Priyankur is also saying yes. So, some of you may not be raising hands because of hesitation, but the fact remains that हमारे पास patient क्या आता है? Normally, मैम मेरे को बहुत दर्द है, निकाल दो बस निकाल दो. Now that's the question. Bleeding ज़्यादा हो रही है. नहीं, हर महीने मैम 5 की जगह 7 दिन 8 दिन मेरे से नहीं रहा जा रहा, निकाल दो. So, these are the most common indications, or discharge. So, 3 common indications I can think of is bleeding, discharge and pain. इसके लिए सबसे पहले इनका एक ही तरीका होता है कि निकाल दो. They may be 37, they may be 35, they may be 30. और I think Amir Khan brought this issue so much into the limelight. उसने एक पूरे का पूरा गांव बताया. एक भी जना नहीं था जिसका यूट्रस अंदर था. Can you believe? Every single person, of course, it brought a very bad light to our profession, but the fact remained that hysterectomy became such a common thing. So, क्या हम यूट्रस निकालने से पहले कुछ सोचते हैं? That's the question. पेशेंट आया, पेशेंट तो बोलेगा, पेशेंट को तो एक प्रॉब्लम है और उसको लगता है इसका सबसे इजी सॉल्यूशन है कि इसको निकाल दो. See, the fact also remains that we know uterus was meant to bear children. तो कई बार किसी का एक बच्चा है तो भी निकलवा लेता है, कई बार उसका बच्चा नहीं है. People for where various commercial interests will do that. So I think common indications तो ये हैं जिसके लिए patient आता है. बाकी there are lot of indications which I can think of. Fibroids, रसौली है. अगर कोई 1 सेंटीमीटर की भी है, 1 mm, 2 mm, 3 mm, 5 mm, 10 mm, and they would come कि मेरे को तो रसौली हो गई, ये कैंसर में बदल सकती है. They don't know. Fibroids are there. They are just benign growths in the uterus. They don't require removal at all. They don't even require looking into. But because ultrasound हुआ, उसमें अगर किसी ने बता दिया कि तुम्हारे अंदर ये 2-3 fibroids हैं, which are hardly even to be seen, but क्योंकि उनको रसौली है, कैंसर बन सकती है, आप निकाल दो. So there is the jurisprudence of the doctor who is treating and who will, and it has happened up to number of times. I'm sure Neharika will and Priyankur will support me on that. कितनी बार patient आता ही ये बोल के कि मैम बस आप निकाल दो क्योंकि रसौली है. And then we are telling them अरे यार intramural है, subserosal है, ये fibroids की importance ही नहीं है. They are there, let them remain. Endometriosis hai, adenomyosis. So, are they symptomatic? Are you looking for fertility? Is the fertility over? Are you near menopause? Are you post-menopausal? What is the age group? ये सब देखने के बाद ही we can actually think of कि hysterectomy चाहिए कि नहीं चाहिए. And of course, this is not the only indication. There are so many indications that you can think of जिसके लिए एक बंदा hysterectomy के लिए आता है. So I think that's where I would say that.
Yes, thank you so much, ma'am, for putting that across. So I think with Bayer, actually FOGSI, I currently am the chairperson of Public Awareness Committee, और हमने काफी सारा programs अभी किए जिस program का नाम है Preserve the Uterus, the part of the mission that we are here today for. So Preserve the Mission, Uterus का जो mission था, this started from 2021, and prior to that we were doing another mission called Save the Uterus from 2018-19 onwards. तो basically ये mission इसलिए चालू किया गया था. In 2018 it was found out in a district called Beed, B-E-E-D, in Maharashtra, where it was found out that 99.5% of women in that district did not have their uterus. And that was a very surprising sort of a finding. And the reason for doing for that was that Beed district basically udhar zyada sugarcane factories and biri factories hai. And it was a tie-up between the factory owners and the doctors over there, जहाँ पे ऐसे बात हुआ था कि this women lose their job 5 days in a month menstrual cycle के time पे जब वो job में नहीं जाते हैं, and उसलिए to prevent that so that the workers come full flow and पूरा महीना आ सकते हैं, they got a hysterectomy done for these ladies. Ladies को ये समझाया गया था कि अगर आप hysterectomy करा लेते हो और आप तीसरी दिन job पे आओगे, you will get an extra incentive. And so both parties agreed and hysterectomy was done. But hysterectomy देखो जैसे मैम ने बताया, definitely the primary role is to bear children, but hysterectomy एक बार कर दो तो ovaries भी function करना बंद कर देते हैं. And once the ovaries stop functioning, your skin changes, bone हड्डियाँ weak हो जाती है, heart में changes आ जाते हैं, which are things that are not good for you. So that is why I think we should try and prevent as much as hysterectomies as possible in the current scenario. So thank you, ma'am, for this inputs. Next, I would come to Dr. Ratna Devi, ma'am, who is a director of PAIR, has got a lot of, a real patient voice, I must say, over here. Thank you, ma'am, for being here. So my question to ma'am would be, ma'am, patients come with a lot of questions to the doctor, ये बोलते हुए कि मेरे को hysterectomy करा दो, but you represent the common voice. So what do you feel, how do you advocate to this woman to, understand that hysterectomy is not right? And how will you try to alleviate the misconceptions that hysterectomy should be done for all gynecological conditions?
Thank you for asking me that question. And you had started the session by saying that it has to be a conversation between the doctor and the patient and a joint decision.
Absolutely.
And not something that is being given or offered from the doctor's side without a discussion. However, most often patients go with the kind of request that ma'am was saying because of religious beliefs, yes, because they feel that it's an impediment to their daily life, or that they are not able to be, if you're living in a large joint family, it's a lot of inconvenience for the woman, and therefore if they are done with their family, they think that it's the best to have this removed, and that actually points to a lot of ignorance within the community. I also want to bring another perspective, and this is from my personal experience. 4 years back, I was diagnosed with a uterine polyp, and when I went for a consultation, I was told, okay, you're done, you're almost postmenopausal, so let's get rid of your uterus. And I'm from the defense, so I went to R&R, and there I was told that we can just do a polypectomy, send it for a histopath, and if there's nothing, you can live the rest of your life without having it removed. So two very diverse opinions. Me being a medical professional, I tried to talk to the person because there was a waiting period in R&R, but I wasn't successful, so I had to go to another doctor. So I think there are two perspectives. So it's the ignorance of the patients that drives them for these kind of requests, but also doctors not, judging or evaluating the patient properly and giving the proper advice, because doing a hysterectomy is easy instead of managing the patient for life. Because things like heavy menstrual bleeding don't stop. Even if you manage it, you can just manage it. And sometimes there will be ups and downs, there will be climatic changes which affect the patient, long distance travel, everything, and that affects the patients so much that they keep going back to their gynecologist saying, this is not curing this, I'm not getting rid of this, I have this problem over and over again, and it needs a lot of patience. But that patience and that time is not there with the specialists because they are so busy. So I think a lot of education and awareness needs to happen at both ends, from the physician side as well. And in metros and in large cities, the physicians or the clinicians by large are very educated. They are up to date with what's happening in the medical fraternity. But you go to tier 2, tier 3, and even within my classmates groups, I see a huge difference between somebody who is in Delhi and somebody who is in, say, Baripada, in a small village in Orissa. So I think that awareness amongst physicians is not catching up with the times. So, and what is the modern methods of treatment? Even surgical methods have advanced so much. But you see very primitive methods still being used in rural areas. So how do we increase the capacity and skill of doctors who are not there in big metros and who are not up to date with medical advances? That is one area that we work as patient groups. We talk to doctors through patient voices, through patient stories, and tell them, this is what the patients are going through. And then we also work with patients and patient groups to help them understand what is necessary and what needs to be done, and how they can then propagate those messages within their communities and families.
Perfect, ma'am. I think the points that you brought in are quite very valid, because of course there is sort of a difference that we see in when we talk, because when we talk across the table, maybe in a panel when we are discussing certain things, there is a definitely stark difference between a opinion that is given by a doctor who probably is working in one of the tertiary I would say the corporate houses, and someone who's working in a PHC. So there is definitely a difference. But then to bring that factor at level, maybe not on a practical ground, but at least on a theoretical ground, like there are a lot of CMEs that are happening nowadays, which I'm sure, and there are a lot of social media partners like ISW, like other partners and etc., where there are a lot of communication, lot of knowledge videos which comes up and which really helps in educating the doctors regarding the same. And of course, ma'am, the other factor is, yes, definitely the doctors, yeah, but then again, when the patient, sometimes, the cost factor plays a role, because the thing is, we cannot even imagine a uterine artery embolization or something called an MRG-FUS for a fibroid uterus in a tier 2 or a tier 3 city. It's only possible in a tier 1 city, but there also the expense is so high that sometimes the patient will not afford it in spite of you telling that, because the insurances also do not cover for such things at some point of time. So I think that is something that definitely also plays a role in a big way. But thank you for your input, ma'am. So next, I would like to come to Neharika, a health influencer herself, and thank you for being here, Neharika. The question for you that I would like to ask you is, how can it be ensured that women are actively included in the healthcare journey and empowered to take informed decisions of their well-being? You do a lot of Instagram videos yourself, so I'm sure you try to bring out that point which will help the patients in taking decision, but across the table when she's in front of you, how do you think you will be helping them in taking this decision towards what they need to do?
So I was here for the last panel also, and I was hearing a lot of all of you talking about equality. And everything goes back to equality. When we talk about why women can't talk about their periods, why they are the last ones to eat in the house, why they can't say that I have fever, I need to go to the doctor. They will not go themselves. They'll go only when it's late emergency. So first of all, we'll have to empower our women to, speak up for daily needs, not just massive needs, but daily normal needs. They won't even go to the market to, buy a sanitary pad. Why are we ashamed of all this? Second thing is, our education system has to improve. Unless we don't know, when I talk to women in villages and all, uterus hota kya hai? You don't, how to tell them all this? They don't understand most of the things. They only know pregnancy होती है, periods होते हैं, खत्म. बाकी क्या है, hormones हैं, क्या आपकी body में changes आ रहे हैं, how should you deal with premenstrual symptoms, menopause, everything. So education will only help. awareness will help. So active inclusion of proper education with mass media and social influencers. Yes, we are talking about social influencers, but the ethical source has to be backed up with it. Most of the social influencers which are there on Instagram or YouTube don't have degrees, and they're talking about things which they should not be talking about. So there has to be a balance of education and what you're spreading, because people listen only, अरे इसके 1 million followers है तो ये सही बोल रही होगी, पर ऐसा नहीं है. So that source also has to, if information has to be backed up, and that's why all of us are sitting here. We are collaborating with each other. We want our own people to come out and educate, because we know that information which is going through this platform will be correct and will be used well and not taken otherwise.
Perfect. I think that brings out the valid point of the more the followers, whatever you advertise for probably sells more. And that goes on to say that our celebrities are now, I won't name, but then there are celebrities who are even advertising for gutkas, which is something that we should not ideally probably do, because that is not something that is right, and that does not help and encourages the youngsters to probably go into it, because if a cricketer like MS Dhoni or Virat Kohli today says something that is considered to be correct, in spite of the fact that they might not have any knowledge on that aspect. And same as you say, the social influencer may not be qualified to do it, but they do it, and since they have followers, so they are the god in whatever they say. So I think that is quite very appropriate. Thanks, Neharika, for that. So next I come to Dr. Ashish. So I think the question to you would be, Dr. Ashish, that how can we facilitate the upskilling and capacity building of healthcare professionals to effectively manage issues like heavy menstrual bleeding? I would specifically ask you on aspect of the non-surgical techniques. Like, what do you feel the non-surgical techniques that could help medical professionals in today's day to probably take care of, like the upskilling that can be done to take care of this woman in a proper way?
Yeah, and of course, thanks for this question, Dr. Priyankur. And most importantly, of course, one, obviously keeping that patient in the center, whatever we are doing is most important thing here. And as you rightly said, we are not talking about the product here, but we are talking about the issue from a holistic point of view. So the issue is not the hysterectomies here. The issue is probably there is lack of awareness regarding the other modalities, or maybe for whatever reasons they are going for the treatment which can be avoided. And in that scenario, probably for sure we first need to educate our patient in terms of the awareness and all, but along with that also we need to give that support to our healthcare providers, because in their day-to-day practice, I mean, if you go to Safdarjung or AIMS or any of those hospitals, and if you walk in during a normal OPD hours, you will see doctors to be surrounded by, I mean, I don't know how many patients are there in the OPD at a given point of time. They see hundreds of patients on daily basis. So it's practically impossible for them to give that kind of a time for the counseling. So there are certain areas where the industry can support the healthcare providers, and that's what we are trying to work with FOGSI, or in fact we try to take the support from the patient organizations like PAYER, where we can try to develop those materials which will help those HCPs to educate those patients in a direct way, but obviously in a very right, informative way. And that's the most important thing. Second, if we think that these are the alternate modalities which are more suitable for that patient, then comes the question whether those HCPs are trained in using those modalities appropriately or not. Because especially with sometimes with this type of a modality, if you don't use properly, then there may be an expulsion, or there may be not so effect which can be seen in that scenario. So in that case, we can always work with the bodies like FOGSI, and we can support them to provide those trainings across I can say the country, but at least predominantly on the, not only in metros, but those tier 2 and tier 3 cities, which is very important, because at least in the metros, you will see that many of the HCPs will have that kind of an exposure to other kind of modalities. It's not that tier 2, tier 3 will not have that exposure at all, but probably their practical use would have been limited, and hence they need to be trained on those use of those modalities in an appropriate way. So that's where the industry can collaborate and can partner with the bodies like FOGSI and the HCP bodies.
Absolutely. I think in addition to, of course, the pairing with the industry, of course, the pairing with organizations we take care of women's healthcare per se, as well as the patient-centric bodies, I think that is very, very important and an apt point. Ma'am, you want to add on something? Yes, please go on, ma'am.
Just wanted to add one point to what Dr. Neharika was saying, about influencers, and probably FOGSI can help us and work with us as patient groups. We see this craze, especially amongst patients who are from far-flung locations like say Assam, Patna, etc., thinking that only doctors in Mumbai, doctors in Delhi are good and all other doctors are not good, which is not the truth. I don't know why the entire family travels all the way to Mumbai just for one surgical procedure, and then they are unhappy because they don't have the follow-up that needs to take place, and then they say that we got this recommendation, we went there, we spent lakhs of rupees, and we didn't get the kind of outcome that we wanted. And a lot of it is driven by influencer doctors who are posting all kinds of videos and doing social media outreach. We don't know how to stop that and whether that is ethical or not, but I think something needs to be done to increase the profile of doctors in all cities, saying everyone is good, everyone who's trained has the ability and the skill to be able to give the same kind of treatment that happens in Delhi or Mumbai. It's not as if you have to travel to only these two cities to get the treatment that you require.
I think what I would like to add on here is, ma'am, I think things are improving, but then it has to improve a lot further. Absolutely correct that there are a lot of people who, like from my part, I come from the eastern part. There are a lot of patients who travel to, from my place, the most common place that people travel to is Vellore. So CMC Vellore is like the biggest institute that can be possible for any of the eastern region, and that is an institute where people go for even showing as smaller thing as gastritis. So we need to understand where we need to go, and plus the important thing that I talk to the patients about is, you may go to a place, you may get a surgery done, but remember you have to get a follow-up done from somewhere else. And it's very important for you to follow up from where you got operated, because that's when you get the best results. And that is something probably patients are understanding. And now things are little better, I would say, but it has to improve further, of course. And I would like to add on to what Dr. Ashish has just said. I think you talked of LNG, IUS, and probably the thing of expulsion that can be possibly there. So I think, yeah, you made a very valid point about the patient selection, because expulsion is something which is not very nice to happen. The patient gets a little bit of sort of a setback, that I went for a treatment which is off the hysterectomy after listening to the doctor, but I got the expulsion done. But there comes the important role of a doctor, where he or she will look into the patient and select the patient well, so that the thing doesn't fail. And Deepak, I think Mr. Deepak from Bayer, he also added on the point of training the PGs. So I think that's a very valid initiative that Bayer has taken up, because I think training from the grassroots level goes a long way in the long run to basically treat a patient in a proper way. Because when we were doing our post-graduations, when we were under our teachers, there were a lot of things we used to do lot more carefree, because the responsibility was on our teacher. We were performing it on behalf of them. But when we are in our own practice, when we are in our own private practice, all the responsibility is on us. And that is when comes the point of, if something goes wrong, what if something goes wrong? And that is when I think training them at a grassroots level, giving them the confidence at that point of time, goes a long way in probably preventing a lot more things, or helping them to treat patients in a better way. Now, coming back to Rita, ma'am. Ma'am, you have talked of the indications of hysterectomy. Next, because now we know that with the ART bill coming in, surrogacy has become a lot tougher. And now with surrogacy becoming a lot tougher, previously we knew there are a lot of patients with probably endometriosis, adenomyosis requesting for hysterectomy and going for surrogacy later on for bearing a child. So I would ask you, ma'am, with this thing happening now, what would be your various uterine preserving therapies, your insight on the previous various uterine preserving therapies that you would suggest, and what do you think is the most effective one?
So, as I said, starting with the indications, heavy bleeding, or let's say abnormal uterine bleeding, for which hysterectomies are done so commonly. I think medically, or trying out medicines is one thing, of course. So, although usually they've tried out tranexamic acid, oral contraceptives, and other medication, progestogens on their own, or given by most of the GPs. But if they have not, then I think it does. And now we have newer drugs like eloxifene, Cevista, all these drugs which are very, very effective. Seriously, I don't remember doing a hysterectomy for any heavy bleeding, because these drugs are so effective and they pass many years, without having any issues. So I think it's very important, as we said, of upgrading knowledge and knowing this. Secondly, building up their, vitamin D, iron, ferritin stores, looking at thyroid, diabetes, looking at the patient holistically is very, very important, and building her up before even thinking of giving anything else, because this itself probably stops the uterine bleeding. Thirdly, I would say endometrial hyperplasia or adenomyosis, for which we have products like LNG, levonorgestrel, intrauterine systems, or copper T laced with progesterones, which when put in will work. I mean, they don't even have to have a tablet every day. So once the Mirena or the LNG IUS is in place, it does the same role. You don't even have to look at it again. So I think it is really, really important that we look at these methodologies before even thinking of. Similarly, discharges, vaginal discharge. Now, whether we are, looking at the discharge, giving kits, government has now decided on number, 1, 2, 6. You can just give a kit. You don't even have to think. Kits which are broad spectrum, they have antibacterial, fungal, protozoal, everything combined. You just have to eat a kit and, get rid of. Or processes like electrocautery, cryotherapy. Look at a colpos. First get a VIA or a colposcopy. It's gaining momentum everywhere. Look at the cervix. Look at whether it really requires any removal. Even if the diagnosis CIN 1, 2 or 3, you have therapies available. So even for milder CIN and even for a CIN 2 or 3, lower grade, they just require looking them again and again and doing therapies like cryo and cautery. So that, and then you have even conizations, TCRE. There's so many uterine preserving therapies which are there, which we can do. Myomectomy instead of a hysterectomy. Why should we compromise on the blood supply of the adjacent organs like uterus and tubes? And why should you get the tubes and ovaries removed first of all? I mean, when they are looking at it. So I think it's very, very important that we look at all these therapies before even thinking of a hysterectomy.
Absolutely, ma'am. Thank you so much for your inputs. I think one of the most important point that ma'am mentioned is the white discharge PV. The hysterectomy is done for that. I mean, that is something, and this is for all of you who are present over here. Please understand that hysterectomy का कुछ common indications होते हैं जिसके लिए कराना चाहिए, and one of the indications that definitely does not exist, I would not say does not, but then very rarely exists, is for white discharge PV. I come from Siliguri, which is like borders the rural part of Assam and Bihar. Huge population of hysterectomies are done over there for white discharge PV, not always by gynecologists, sometimes by other disciplinary doctors as well, which is not something which is right. So I think that is something. And remember, आपका family में कभी भी कुछ भी, in case if it leads to anything related to the reproductive organs, uterus, ovary, cervix, etc., it's the gynecologist that you have to first of all go and visit, and not someone from other discipline. That is something I think goes to us as doctors, plus goes to you to select the right discipline for better management for your own patients. Number two point.
I will agree with that, Priyankur, because surgeons, yes, specifically, because they have instruments in their hands,
yes,
they don't have the, they are not looking at the fine aspects like we talked of reproduction and fertility. Okay, and just nikala and finish.
And that too, in some instances, it's not even a total hysterectomy and a subtotal hysterectomy done, and that is not something that is right. I think the second thing that I would like to bring in is, because ma'am talked a lot about cervix just right now. आप लोग का घर पे, you guys are quite youngsters. You have got youngsters below you. You have got seniors in the family. Remember, the government of India has brought in the HPV vaccination program now, and the HPV vaccination program is going a long way in preventing the cervical cancer thing in the country. So remember, HPV vaccination is in the government of India schedule. Will be available in government of India vaccination program from late December to January. Please make use of this program. The vaccination is going to be available at a very minimal cost, and it is a vaccination which is known to prevent cervical cancer by almost 99.5%. So it's one of the preventable cancers that we can talk of now. And I think that is something that is very valid and should be utilized for the best benefit of your known people, your peers, your friends, and all of you. Please to counsel them regarding the same. Okay, now coming to Ratna ma'am. Ma'am, I think there are a lot of patients who go to a doctor and probably come back to you and later talk to you. So what do you think is, what do they talk about the communication that happens between a patient and a doctor? Is it improving from what it used to be before? When a patient, suppose a doctor gives a suggestion of hysterectomy, the patient, do they have an option of, talking back? Do they have an option of communicating, a bilateral sort of a communication after that the decision is taking. So what do you feel is the feedback of patients in today's day as per how things are improving or going ahead in healthcare in the current scenario?
I think doctors are much more perceptive now to patients, and even though they are busy, they like to spend time because then the outcomes are better.
And your, as a patient-centric approach facility that you run, so what do you feel your role for the same is like? Suppose a doctor has told, okay, this is your option. What do you want to do? And how do you sort of try to probably help them to come to a thing which will benefit them in the long run?
So we don't interfere in that, because at the end of the day, it's the doctor who can have the best judgment because they know how to evaluate the patient. What we tell them is that if you are not comfortable with whatever is being given to you as a suggestion, go back and think over it. Talk to your peers, talk to your family, look for information from authentic sources, and then go back to the same doctor. Usually the mistake that patients do is they will junk that doctor and go to a new person and then seek one more advice, and then after 3 such visits they are confused which one is the right one, especially if there is a diversity in the kind of advice that is being given. But having said that, I've seen that doctors are much more they spend time with the patients because they know that if they spend time, then the compliance is better. Patients will listen to what advice is being given. And once the patient follows the doctor's advice, usually the outcomes are good. It's only when they do not follow that the outcomes are not good. Of course, there's a lot of diversity, like I said before. So while there are these very compassionate doctors who will spend time, go out of their way, do a follow-up on a phone call and say, are you comfortable? Shall we go ahead? We will do it after 2 months if you're not comfortable now. 2 people who will push for it, for commercial interest. So it's very difficult to put everything into one bucket and say everybody is good or everybody is bad. But what I would like to also emphasize is that in many cases we have seen that even though the doctor doesn't have the skill or has not been successful in treating, they will not refer. And that is terrible. You go on playing with the patient's, life, and you go on experimenting till it reaches a level where they get fed up and then they go to another doctor. And then they realize how much of harm has been done to them over and it's sometimes 3 years, 4 years, 5 years of treatment. I think that should stop. That is not right. If you feel that you're not able to manage whatever the problem is, then please refer to somebody who's more skilled and better than you. But I think because they want the patient to stay with them lifelong, they do not refer.
I think valid points brought forward. I think ma'am talked, the words that she used were very appropriate to what it is in today's day. And I think the 3 important things that ma'am has talked of, number 1 is continue with the same doctor as long as you feel comfortable to be with him or her. Number 2, relationship of the doctor and patient is of paramount importance. Remember that. Never interfere in a decision that has, or a dialogue that has happened between a doctor and a patient. She runs a patient-centric group, but she still says that she does not interfere in the discussion that has happened between the doctor and the patient. The discussion is between the 2. If you do not understand it, good, go back to him or her and ask her the same question again, and then find out what you feel is appropriate and take a decision according to that. I think that is important. And number 3, from our perspective, I think if we do not understand something, take an opinion yourself from someone, asking that, give a call to one of your seniors and ask, so and so patient ka aisa hua hai, kya karna chahiye? Do it. If you feel you are a little too big to do that, refer the patient itself to someone else. I think that is a better way of doing it, rather than keeping the patient with not doing anything to her. I think that is something I guess is not right. Thank you, ma'am, for bringing out those points.
You want to add on? Just one more thing.
Yes.
Gynecology is very interdisciplinary, meaning you have IVF specialists, you have obstetricians,
Yes.
you have gynecologists, and a woman has a whole life cycle.
Yes.
But these 3 specialities also don't talk to each other several times. And I think that communication gap also needs to be bridged. So if a woman is being treated for, say, endometriosis and then has reached a level where there is infertility and goes to an IVF center, refer back to the gynecologist once that, conceiving has happened or the baby is born or whatever it is. That doesn't happen. And the woman then goes to maybe some other doctor, not the initial one who was treating the endometriosis, and there the confusion starts.
So I think it is more of a fact, as you say, I think it's more of a fact of now I think again I would say that it again depends on where it is, because I think in smaller places things are a little better, because the thing is we have our sort of group, it's I think what is called a group practice in today's day, because we have our own sort of colleagues, our own peers, where we do this interdisciplinary thing, which makes things a lot easier for the patient. And now we have also started something else in the hospitals, which is called specialty clinics. Like we have something called an infertility clinic, a gynecology clinic, a high-risk obstetrics clinic, a menopause clinic, which runs in the same hospital. And you know, they know that they have to come on a Tuesday for so-and-so doctor, they have to come on a Wednesday for so-and-so doctor. And when they go there, they usually see the same face. If maybe he or she is not there, maybe someone else. But then at least the thing continues. I think that is a much easier way of doing things in today's day, because that culture is coming in now. And I think that was, again, quite appropriate. Now, Neharika, coming back to you again. I think social media platforms we have talked of, it creates a lot of mass awareness among the women's health and the different taboos. So what do you feel like? We have talked a little bit about social media. We have talked of things that some people should and some people shouldn't talk of. But what do you feel in your perspective should be the things that we have the right to talk about? And do you feel that, you know, counseling things which probably we are not good at, should that be one of the things that we should do?
So, of course, social media is a very powerful tool. Yesterday, I was addressing a college of 1,000 girls between 16 to 18 years, and I asked them, how many of you have an Instagram account? 90% of them had an Instagram account. The next question I asked them was, how many of you have done your annual medical checkup? I think only 2 of them, stood up. So imagine the shock. You can have an Instagram account, but you cannot go to a doctor once a year for your own health. So that's the power, and we have to use that power now. If they can have an Instagram account, they can also understand they have to look after their own health. Why are we only focusing on social media on fashion, lifestyle, selling things? Let's use it to benefit our community right now. When we talk about social media, I'm a gynecologist. I would like to stick to topics which are related to me. I would not go and talk about, oh, you have acne, you should get laser done. Why should I talk about it? That's the job of your dermatologist to talk about. And I think unless we on social media understand responsibly कि मुझे क्या बात करनी है, it won't change. So if you are a gynecologist, stick to your education, talk about those things, because it's so many people, you'll still be very popular. You need not discourage other fraternities or discourage anything else. You'll grow in your own space. And when we're talking about, doctors not referring to other people, ma'am, I would just like to add, we were grown to run that rat race. I was in medical college. Unit 1 ने 10 cesarean करे, अरे Unit 2 ने तो 2 ही cesarean करे, Unit 3 ने तो कुछ भी नहीं किया रात को. And you're fighting for that, every day. And, why can't we change that mentality? We are not in that rat race. अभी भी हमें लगता है, oh, that surgeon did 10 hysterectomies, they announce on Facebook, laparoscopy batch हो रहा है, 34 cases done in one day. Why would you want to do 34 cases in 24 hours? You're not even thinking about post-op management. So we also as doctors have to evolve and understand that it's the quality which will come first. It's not the quantity, and we have to change on that.
Thanks, Neharika, for bringing in that point. I think you brought it very appropriately that, that age where we probably, all of us are of the same generation, and I think we were playing with the fridge doors to open and see whether the light gets off when we close the door. People are having their Instagram accounts nowadays, and they are on internet and doing all sorts of things over there. And sticking on to your own discipline is something that is very, very appropriate, and I think we should do it in respect to whatever we do. Dr. Ashish, I would like to come to you about the industry's involvement regarding the initiatives towards patient healthcare, and what do you feel also should be the initiative from the industry towards social media? Now that we are talking of social media, what do you feel what is the role of the social media in the industry in basically in the social media for improving the health of women or bringing the patient perspectives towards that? What do you feel the industry should do or benefit the women in that perspective?
Thanks. I will answer this in 2 parts. First, the industry's perspective towards patient. Now, I can tell you that if probably this platform would have happened a decade back, we would have been very hesitant to participate in a program where we are directly interacting with the patient, because unfortunately we are always dealing with the prescription-only products. So we have been hammered by all the legal angles that you cannot go and talk to the patient, and that's right. So, but then gradually the industry learned that there were restrictions on talking about the product. There were no restrictions on creating the awareness regarding the disease. And that's probably has come a long way now. And that's what we learned, that we have been talking about things that let's do things for the patient. From that, now we have moved a needle to let's do think with the patient. And that's very important. We were trying to sit outside and then trying to think what are the best possible options for that patient. Now probably the patient is in the center and we are including that patient in the decision making. So that's one important change which is happening, but of course it still has to go a long way. But that's very critical because here we are not talking about a particular procedure or a particular product. We are talking about the involvement of the patient in their own healthcare related decisions. And for that, it is very important that for them to be involved in that, understand all those things properly, and then take a decision. So there are various examples which we can try to do, like right from the research, we can involve them in designing the protocols to see how they are suitable, because sometimes we design the protocol the way we think, and then we realize that it's very difficult for the patient to follow that. One simple thing can be if you plan a clinical trial for a drug which acts on the menstruation, and if I ask them to use those tampons and then bring it back every time during the visit, it's unrealistic. You really can't do that. So I really need to understand that what are the problems of the patient and what I should address it. So that's one thing. Once you gather that information from the patient through those patient group discussions or whatever, then you need to act on it. And there you can try to come up with those solutions which are more suitable for them. And the last but not the least, what you should do is that then you should circle it back, showing that these are the solutions which are designed. Now, are they effective? Because we should not again start assuming things that, yes, these are done like that. Now, I will come to the second point of social media. So, I mean, these are the topics which we have been debating since ages. You know, when we were kids, probably that time there always used to be a topic of essay, this television is good or bad. So things are not good or bad. The way we use them makes them good or bad. And that's something that we need to keep in mind. So social media per se is not bad. The challenge is for that patient to find the right information on social media is important. And that's where we can work with the bodies like FOGSI, where we can have those digital TLs, what we call them. So these are the educated experts who can give the right type of information regarding the disease, for the awareness, for the treatment. I'm not talking from product point of view, in general. And then those patients can follow them on the social media rather than following a general social influencer. That will be a right way of doing it.
You want to say something? Okay, no. So I think, Dr. Ashish, that was quite a important and a valid point, I think, because we have been for quite some time trying to, you know, as we all know that there are a lot of, like ma'am talked of Uterus, talked of a lot of social media handlers that are there who on their individual perspective, they bring out a lot of videos, which may be right, may not be right. But again, the important point here that you made is we make through platforms like suppose FOGSI, or any other body that is there are bodies like ISPOR, ISPOR, etc. Bring in those material which is validated and then circulate it in the social media. But the problem that we face in doing that is basically social media is now no longer a cheap media. It definitely has got expense, and that expense, once we have like people like industry partner like Bayer or some other industry partner who is ready to, you know, support us through that, that makes things a lot easier, because content making and content creating is one thing, publicizing and circulating it is something. So that is not like one ball game, and there has to be a team approach for that as well. And definitely I would like to again thank Bayer over here, because they've helped us a lot over the last 4 years or so in bringing out a lot of change in trying to preserve the uterus. We have been like doing these programs like over the last 4 years, as I mentioned. So हम लोग का भी ऐसा है कि we cannot like have a direct data of because of these programs कितना hysterectomy हमने prevent किया है. But what we are doing is in a like, you know, you catch your nose from behind your head. What we are doing is, जैसे suppose we have done these programs in 58 to 60 places physically. तो उधर हम लोग क्या कर रहे हैं कि suppose the number of LNG-IUS units that were used at one point of time was 10. But now suppose we are using 50 units over there. So what we go on to say is that 40 hysterectomies could be averted because the usage has increased so much. I think that is one way we are doing it, and we have seen the paramount increase in the number of usage. That means that the number of hysterectomies had come down in a long way. And that I think is quite very useful. Thank you so much, Dr. Ashish. Now we'll go for a last round of quick fire questions before we end this panel, with all of you. So I would first come to Rita ma'am. And ma'am, the question to you would be, hysterectomy, yes, definitely when it's indicated should be done. So what in your perspective or your aspect do you feel the different modes of hysterectomy, like abdominal, vaginal, laparoscopic, or V nodes, etc., that has come in, what do you feel is the most appropriate on a patient-centric way for them for the better healing of theirs? And do you feel if a patient wants a laparoscopic approach and you cannot do it, do you feel that bringing in someone or referring to someone is a better way of doing it rather than explaining to them, nahi, yehi acha hai? Which one do you feel, and how should we counsel the patient?
I think it goes without saying that, there are some indications like we talked of, where it is essential, say carcinoma or multiple fibroids which are, say uterus is say 30 weeks size. So these are the indications for which hysterectomy has to be done. And of course, with robots also coming, so robotic is also another way of dealing with uterus now. I think there is no doubt on, we are advancing, and laparoscopy has definitely an edge over an open surgery. And I don't think anybody should be shying away from the fact that if it is a better way and if somebody can do it better, then definitely, or you train and skill yourself. So I think there is no doubt on that. Laparoscopy is definitely, minimal invasive, as we call it. So when you are really doing something which is minimally invasive, that definitely will have an edge over an open surgery. And I think that would be a right way.
Thank you, Rita ma'am, and also the perspective, of course, that you are a gynecologist and hysterectomy is our purview and we do it, but then the best approach, the best way which will help the patient for a faster recovery. Thank you, ma'am, for that. So, Ratna ma'am, your question would be, we have a lot of challenges when you communicate with the patient regarding any sort of treatment. I'm not talking of hysterectomy only now. So what do you feel the challenges are primarily that you face when you're communicating with the patient regarding any treatment? Suppose they've gone to a doctor, they've come back with an opinion, you're discussing things with the patient hasn't understood few things, like as you have already said. So when you communicate these things with them, what are the challenges that you commonly face while discussing this with the patient?
I think the challenges are more based on whether there is a trust. Where there is a trust, there is no challenge. The patient is completely, dependent on the doctor and goes blindly with what the doctor says. It's only where there is distrust or mistrust or there's a question of paying capacity, etc., do the questions arise. So one issue that I think we can do to improve communication is to make that appropriate material available on a site that is trusted by all. And therefore, the frequently answered questions kind of a thing where people will go and read about it before they can, raise those questions themselves. But a quick comment to what Dr. Neharika said about stick to your profession, that is not just for modern medicine. It's more for the, professions that are outside of modern medicine, because that is where the misinformation generates the most. And I think to counter that, the best way is to have a very strong modern medicine voice, both from the providers as well as organizations like mine, which patients trust, so that they get the right information and then this whole distrust goes away.
I think the points that we have repeatedly made over here is the fact that I think information coming from trusted organization bodies are some things that should come forward in the future, so that will give more validity to whatever we are saying. I think that is what we all of us who are present over here looking at, and I'm sure the audiences will also agree to what is being discussed over here. Now, Neharika, your question would be, what initiatives should be taken to educate young healthcare professionals about uterine preserving therapies? We have a lot of youngsters present over here. So what would be a one-to-one advice to all of them regarding uterine preservation, not only for them, but also a sort of a counseling point for people who are present at home in their families? So what would be your one-to-one discussion?
I was thinking about this question, and I think it has to start from our medical education. जब भी कोई बुक्स मेडिकल बुक्स पढ़ते हैं एंड व्हेन यू से ट्रीटमेंट ऑप्शंस द फर्स्ट ऑप्शन इज हिस्टेरेक्टमी व्हाई वी हैव टू हैव ऑप्शंस बट वी शुड नो व्हाट ऑप्शन व्हेन सो अंडरस्टैंडिंग व्हाट ऑप्शन व्हेन यू आर सिटिंग इन दैट ओपीडी एंड लिसनिंग टू योर टीचर्स सेइंग कि इसका हिस्टेरेक्टमी करना है, क्यों करना है, कुछ और कर सकते हैं क्या. पेशेंट ऑल्सो हैज़ टू स्टार्ट आस्किंग ऑफ ऑप्शंस एंड वी हैव टू गिव ऑप्शंस कि हाँ इसके ये हिस्टेरेक्टमी हो सकता है, मेडिसिन हो सकती हैं, इंट्रायूट्राइन डिवाइस हो सकते हैं, सबके सक्सेस रेट ये है, एविडेंस ये है, लॉन्ग टर्म प्रॉब्लम्स आपको हिस्टेरेक्टमी के बाद क्या आने वाली हैं. सो मेडिकल एजुकेशन सिस्टम हैज़ टू इवॉल्व एंड टॉक लाइक दैट. We don't have to have a full question on always on hysterectomy. We can have a full question on intrauterine devices. So the thinking of junior doctors will start changing. Oh, this was a better option. मुझे पता होना चाहिए था. Why only those important surgery-related things are highlighted more? We have to start highlighting alternative therapy, yoga, physical therapies. You know, everything plays a very important role, especially in women in this age group who might need hysterectomy or who is in that category. Because her healing will also depend on her mindset. So change the medical education system, start from that, and I think things will fall into place.
I think quite appropriate again, Neharika, the point that you brought in. I think in today's day, it's quite important for us to counsel the patient well. And after the counseling, I think all of us will agree, especially the ones who are in the dealing with the patient in the front and treating your own patients. I think consent is something that is again very, very valid. So good counseling followed by a good documented consent goes a long way, not only, saving that mistrust that happens between you and the patient, and also to bring in the point that whatever we have done for the patient is documented, and later on in case, because we all know that things can go wrong. And we should, other thing that I always say, and I tell my patient is, I will probably promise you 90% and deliver 100, rather than promise 100 and deliver 90. Because that's when, again, the litigation, the things that you have not done what you said, etc. comes up.
I'll just add here because we have a very wide audience. You know, no doctor wants a complication.
Exactly.
We don't want to give you complications, but then we are not God. We can have complications, we can make mistakes, and that's where the trust has to develop, because it can happen to anyone. From the most experienced hands, complications can happen, and you have to understand that.
Exactly. And again, since we're talking of hysterectomies now, very pertinent to this, I would say, like when we started off doing lap hysterectomies, maybe 5-7 years before, we had very less complications. But now, considering the fact in the next 10 years, all the hysterectomies probably we'll be doing on patients who had previous surgeries, like previous cesarean sections, etc. And we are bound to have complications in them. And one thing we know for sure, जो भी डॉक्टर बोलता है कि कोई complication हुआ नहीं है, मतलब वो ऑपरेट नहीं किया है या झूठ बोल रहा है. Complication to hona hi hai if you are working. So that is for sure. And then we have to understand, the patient also needs to understand. Basically, if we have done 99 good surgeries and one might have complication, that does not mean that we complicate all patients. But then it can happen, and it is a thing that is written in the textbook as well. So again, Neharika, thank you for your input. Now, the last question for Dr. Ashish. Industry is working very hard, I'm sure, to bring up nice products which will help our women per se. So how do you think, because we also have to, bringing in nice products always comes with a cost. So how do you bridge that gap in this competitive market between bringing in good healthcare products and also trying to bridge a gap to make it economic for the buyers, that is the clients, to buy it? So how do you feel that bridging of gap is important, and how will it improve the healthcare system in the country?
Now, this is probably not only the challenge related to this topic, but it is a challenge in general. And it's a very, very complex topic. The topic of access is very difficult to address in our country, especially because we belong to a different healthcare system, which is rightly so, because you cannot compare the US healthcare system and expect our government to follow that system as it is in India. It's a 1.4 billion population, and we are still now in a developing stage, but of course we do have that target of becoming developed country by 2047. What can be done is only one thing. All the stakeholders need to come together and act on that. It cannot be addressed by a single stakeholder. For example, patients, there has to be awareness now more for the patient that you need to go for the health insurance. You need to select the right health insurance. I'm not talking about taking any insurance and going for those kind of things. Of course, government is doing their bit, right from the Ayushman Bharat to many of those state authorities are doing and trying to include many of those treatment options in their thing. Industries are also trying to come up with their own ways of doing things. Sometimes when we develop product, a lot of R&D investment goes into that, and there are comparisons between the different market. Hence, it becomes challenging at times to come with that product with a very, very low price. But there are other modes of addressing those issues, in the sense you can then provide the patient support program in select cases and can try to make that drug, I will say, more accessible, not only affordable. Because I can tell you that we have seen many scenarios where actually in our clinical trials we have given the drug free of cost, still we have struggled to find patients. So price is not the only factor that can solve that issue, but it has to be solved at multiple levels, especially in oncology. If we do not have good diagnostic modalities, I am actually struggling to find the right type of a patient at an early stage in a non-metastatic stage, when the drug is there for a non-metastatic stage. So all the insurance providers, right now our insurance is so heavily dominated by only hospitalization reimbursement. That has to go further, they have to start at least including some of the important treatment options. Now, India, forget about preserve the uterus, India is becoming a diabetic capital slowly. And you see none of those diabetic therapies are included. I'm talking about the OPD medication, they are included in the insurance. So somewhere they have to go, of course they will charge their premium accordingly. We should be willing to bear that premium. Nothing will come free of cost, that's for sure. And that's applicable for us as well. So please do not consider that if we are sitting here as an industry, we are not facing those kind of an issue. It's the same thing. Even today, if I am insured for the hospitalization, not for any of my OPD medication. I will be buying those medications out of my pocket. Now, if someone gives me that option that I will cover this XYZ medication, I am giving you a little premium of that insurance, I will opt for that actually. And that awareness has to increase. Rest, obviously, the HCPs are doing their job. It's not an easy job for the HCPs in India. It's the volume that we are talking about. And now we are expecting them to provide the value along with the volume, which is the very, very tricky scenario. But I'm sure the good healthcare systems are coming up, good setups are coming up. They will become more economic once we get into that volume kind of a business, and that will become better. So if all the stakeholders, they collaborate with each other, we can go far distance. We will never be able to solve that issue for each and every of those 1.4 billion people. But I'm sure by addressing that in a collaborative way, we will be able to address it for many of them actually.
Perfect. I think healthcare providers, industry partners, patient representatives, patient voice bodies like what ma'am represents, I think all coming together and bringing out a statement is where I think we will end. And also social media, of course. The various platforms that are there who will reach, because it's not important for you to sit on a table in Pragati Maidan and discuss something and thinking that 1.4 billion people will hear about that. So it has to go through a media. It has to go through a channel by which it will reach people. And now we know that with the system, with the informatics that has improved in the country, now internet has reached the smallest of villages as well. And I'm using them in a proper way because as you all have mentioned, that social media is not bad. Nothing is bad. It's how you take it and how you use it. That is what is important. And the best viable way of using it and the best way of using it to make it reach positive information, reach people is something that we are looking at. You are very true when you say that the medical system in India and the medical system in the Western world is completely different. This is, of course, to understand that how much ever money we pump in our medical system is going to be lesser because we are dealing with 1.4 billion people. And they are probably dealing with 14 million at the most, maybe most of the countries if you look at. Each state in India currently is probably equal to a population of a country elsewhere that we can definitely look at. And I think you are talking of various systems like, in India, whenever we buy an instrument for, especially suppose a private hospital or something, if it's in even a disposable handpiece, something called a harmonica instrument that we have, it's a disposable instrument. But we ask probably the guys buy from, how many cases can we use this for? So those are things that are then, when we go to the Western world, Western OTs, we sometimes see those instruments that are, in one patient they use 2 or 3 instruments, saying that this is not working, this is not good, that is not good, and we do not have the, the liability, the capability or the financial backing for doing something like that. But I think probably, as you said, India is going to become the 3rd largest economy soon, probably in the next few years, and then that would probably help us in the same way. So I think we will end this discussion here because there is, of course, the patient voice is something that is of paramount importance, and we can talk about it for hours together. But I think we will come to the end of this discussion, and I would really like to thank Dr. Rita Bakshi for being here, ma'am. Thank you so much for your inputs. Dr. Ratna Devi, ma'am, thank you, ma'am. It was a pleasure having you here. Dr. Neharika, thank you so much once again for being here. And Dr. Ashish, of course, representing our industry partner as well. Thank you, Dr. Ashish, for all your inputs. And overall, I would like to thank ISW, Bayer, and all of you who are present over here till late this evening for being here for this session. Thank you once again.